What if the very treatments doctors have been injecting into your joints to save them are actually accelerating their destruction?
Yeah, that is the uncomfortable reality we're facing today.
We're convening this deep dive not as a casual conversation about wellness or, simple longevity hacks. This is an urgent medical investigation.
Absolutely.
For those of you listening right now, especially if you have crossed the age of 45, what we are about to unpack over the next hour directly dictates your future physical independence.
It dictates everything, your mobility, your cardiovascular resilience, and, frankly, your ultimate lifespan.
Right. Today, we are dismantling a pervasive, highly destructive medical dogma that you have almost certainly been told is absolute biological truth.
And it is a dogma that carries an immense psychological weight for people. I mean, for decades, patients have sat in clinical examination rooms staring at x-rays of their knees or hips.
Staring at that bone-on-bone image.
Right. And they have been told by well-meaning physicians, cartilage cannot regenerate. Once it's gone, it's gone.
Which is just a devastating sentence to hear.
It is. And based on that single sentence, millions of people have resigned themselves to a grim trajectory, a life of shrinking physical world.
Escalating chronic pain, too.
Exactly. The eventual surrender of the activities they love and the inevitable dread of total joint replacement surgery.
And the gravity of that resignation, it just cannot be overstated. When a weight-bearing joint fails, it is never just a localized orthopedic problem, is it?
No, not at all. The systemic architecture of an aging adult begins to collapse.
Because if your knee hurts, you stop walking.
You stop walking, your cardiovascular health plummets, your metabolic flexibility degrades, and, quite frankly, your risk of all-cause mortality skyrockets.
It's a terrifying cascade. So we are looking at a paradigm that has governed orthopedic medicine for generations, dictating how we treat, or rather how we fail to treat osteoarthritis.
We really have to fundamentally re-examine everything we thought we knew about joint preservation.
Which brings us to the source material for today.
Yes, the recent data. Specifically, the late 2025 Stanford medicine study concerning cartilage regeneration pathways.
Alongside some really critical analyses of current osteoarthritis protocols. And I have to say, looking at this data forces us to confront some very dark realities about standard care.
It really does. The biological mechanisms of cartilage decay are just widely misunderstood, not just by the public, but often within the standard clinical setting.
Okay, so to understand the Stanford breakthrough, we first have to investigate the active biological crime scene of a degenerating joint. We need to redefine osteoarthritis completely.
We do.
Because for as long as I can remember, the medical community has pitched this as a wear and tear issue.
Right, the car tire analogy.
Exactly. You drive the car for 60 years, the tread wears down to the bald rubber, and eventually the tire pops.
But if you look at the cellular biology, that mechanical analogy completely fails to capture the violent reality of the disease.
It completely misrepresents the pathology.
It really does. The wear and tear concept implies a passive process. It implies that your cartilage is just an inert shock absorber slowly eroding over time.
Just scraping away.
Right. But osteoarthritis is not passive. It is an active, aggressive, cellularly driven disease.
It's a highly coordinated biological attack on your own tissue.
Precisely.
So let's visualize how this actually begins in a human knee. Imagine the pristine, smooth, white surface of healthy joint cartilage. It is essentially frictionless.
Like wet ice on wet ice.
Right. Now imagine a dark spot appearing on that surface. A focal lesion, let's call it what it functionally is, a pothole.
A pothole is a perfect way to describe it.
So if you have poor joint mechanics, a history of trauma, or you are carrying a repetitive asymmetrical heavy load, every time you take a step, the physics of your body weight drives directly into that pothole.
And remember, that force can be 3 to 6 times your actual body weight across the knee joint during dynamic movement.
Wow, so all that force just slamming into this tiny defect.
And this is exactly where the mechanical failure initiates. When that massive force hits the compromised area, the edges of the pothole begin to shear.
They break apart.
Yes. Yeah. Microscopic fragments of the cartilage matrix break off.
But those fragments don't just disappear, do they? I mean, they don't just float harmlessly in the joint space.
No, they don't. And this is the crucial pivot from a mechanical problem to a catastrophic biochemical shift.
This is the part that blows my mind.
And it is the exact mechanism that most patients are never taught.
Right.
The knee joint is encapsulated by a highly sensitive, vascularized lining called a synovium.
And its primary job is to produce synovial fluid, right? The lubricant and nutrient bath for the joint.
Exactly. But when those jagged microscopic fragments of degraded cartilage break loose from our pothole. They act like biological shrapnel.
Shrapnel, that is a visceral word.
It's accurate, though. They embed themselves into the synovial lining.
So the joint is essentially choking on its own structural debris?
It is. And the synovium reacts violently to this. The synovial tissue is packed with immune cells called macrophages.
Okay, the cleanup crew of the immune system.
Right. When these macrophages encounter the cartilage debris, they phagocytose it, meaning they eat it.
Which sounds like a good thing. They are cleaning up the mess.
It sounds good, but it triggers a complete panic response.
Why?
Because the immune cells recognize the structural proteins of the cartilage as foreign material. They are not supposed to be floating freely in the joint fluid.
Oh, wow. So they think it's an invader.
Exactly. So the synovium initiates a massive localized immune response.
An inflammatory cascade.
A highly toxic inflammatory cascade. The synovium starts pumping out aggressive signaling molecules.
Specifically, the data mentions cytokines like interleukin-1 beta and tumor necrosis factor alpha.
Yes, IL-1 beta and TNF alpha.
Let me stop you there because we really need to translate those terms for the listener. When we talk about interleukins and cytokines, what are they actually doing to the joint on a physical level?
Think of them as chemical messengers shouting instructions to the surrounding cells.
Okay.
These specific cytokines flood the joint space and bind to the receptors on the healthy cartilage cells, the chondrocytes.
The cells that are supposed to be maintaining the joint?
Right. Normally, chondrocytes quietly maintain the cartilage matrix. But when they are hit with interleukin-1 beta, their programming is completely hijacked.
Hijacked how?
They stop building cartilage, and they start producing enzymes called matrix metalloproteinases, or MMPs.
And what did these MMPs do?
They are essentially molecular scissors.
Molecular scissors.
Yes, their sole biological function is to cleave and destroy structural proteins like collagen.
That is horrifying.
It is. So the inflamed synovium essentially orders the healthy cartilage cells to release the enzymes that actively dissolve their own surrounding tissue.
So treating osteoarthritis simply as a structural problem, which is what we do when we point at an x-ray and say, look at that bone spur, is completely missing the point. It's like looking at a burning building and only worrying about the compromised foundation, completely ignoring the blazing fire that is actively melting the steel beams.
That is an incredibly apt way to frame it. You cannot fix the structural foundation of the joint while the inflammatory fire is actively driving the localized cellular suicide of your cartilage.
This is why a patient will say, my knee was fine last year and suddenly it's destroyed.
Yes. The mechanical pothole was just the spark. The inflammatory engine is what actually burned the house down.
And what makes this reality even more devastating is that there are systemic amplifiers pouring gasoline directly onto that localized joint fire.
Oh, absolutely.
Because if we look at the data surrounding metabolic health, the narrative gets much, much darker.
It does.
We used to think that obesity only caused arthritis because of the sheer physical weight bearing down on the joints.
And, well, the biomechanical load of excess adipose tissue is certainly a factor, yes. Force equals mass times acceleration.
Right. The physics matter. But the literature shows something much more insidious. It's not just the weight, it's the biological nature of visceral fat.
Exactly.
If a patient is carrying significant visceral fat, that deep belly fat, that tissue is not biologically inert.
No, it is highly active.
It is an active endocrine organ constantly secreting systemic inflammatory cytokines into the bloodstream, adipokines.
Precisely. Systemic metabolic dysfunction lowers the threshold for localized inflammation.
So the body is already primed to overreact.
Yes, if your baseline metabolic health is poor, if you're insulin resistant, or if your diet is highly inflammatory, your immune system is already hypervigilant.
It's on high alert.
So when that tiny mechanical pothole forms in your knee, your synovium doesn't just mount a proportional response. It overreacts wildly.
The systemic inflammation acts as an amplifier.
It does. The inflammatory engine accelerates exponentially, eating away the joint architecture until you reach the catastrophic endpoint, which is bone grinding on bone.
It is a terrifying biological domino effect. The pothole causes the debris. The debris triggers the synovium releases interleukins, the interleukins trigger the molecular scissors.
And your metabolic state dictates the absolute speed of the destruction.
It forces us to look critically, and I would say with a deep sense of medical apprehension, at how modern medicine is currently battling this process.
We have to evaluate the standard protocols. We must.
Because when you map these interventions against the biological mechanisms we just detailed, The current approach is deeply flawed.
In many cases, it is profoundly inadequate,
Mm.
and in some, as we will discuss, it is actively accelerating the pathology.
Let's walk through the patient journey. Before a surgeon will even discuss a joint replacement, they mandate non-surgical protocols.
Always.
So a patient wakes up, their knee is stiff, hot, and swollen from that synovial panic response we talked about. The first line of defense is medication.
Right, specifically non-steroidal anti-inflammatory drugs, the NSAIDs.
Ibuprofen, naproxen, meloxicam. These are the pills millions of adults swallow every single morning just to be able to walk down their stairs.
NSAIDs are the cornerstone of early intervention. And mechanically speaking, they make sense for symptom management.
How so?
Well, they work by inhibiting the cyclooxygenase enzymes, COX-1 and COX-2.
Okay.
By blocking these enzymes, you halt the production of prostaglandins, which are key mediators of pain and inflammation in that synovial cascade we discussed.
So the swelling goes down and the patient regains some function.
Exactly. The joint cools off.
But we need to detail the alarming systemic downsides of these medications when they are used chronically.
Yes, we do.
And by chronically, I mean the millions of people who take them daily for years. We are not talking about a 5-day course for a sprained ankle.
No, this is long-term daily exposure.
When you systemically block prostaglandins, you are not just targeting the knee. Prostaglandins have vital protective roles throughout the entire body.
This is the biological trade-off patients are rarely counseled on in depth.
Let's talk about the stomach.
Right. Prostaglandins in the stomach lining are responsible for stimulating the production of protective mucus.
To protect the stomach from its own acid.
Precisely.
Yeah.
When you chronically suppress them with NSAIDs, you strip away that defense.
Wow.
We see severe chronic gastrointestinal irritation, ulceration, and even catastrophic GI bleeding.
Just from trying to manage knee pain. And it doesn't stop at the stomach. What about the renal system?
Prostaglandins also regulate blood flow to the kidneys.
Yeah.
Chronic NSAI use causes renal vasoconstriction.
You are essentially strangling the blood supply to the kidneys.
You are, which leads to chronic kidney disease over time.
That is just bleak.
Furthermore, they can destabilize blood pressure because of how they interact with the vascular system and fluid retention.
So you are forcing your major organs, your stomach, your kidneys, your cardiovascular system to pay a massive biological price simply to suppress a localized joint fire.
That is exactly what is happening.
Which logically pushes both doctors and patients toward the next step in the protocol, which are joint injections.
Right. The rationale is understandable.
If swallowing a pill destroys the stomach and kidneys, why not deliver the medicine directly into the localized area of the knee? Spare the systemic organs.
It makes sense on paper.
And this brings us to the most common joint injection on the planet, the intra-articular corticosteroid.
The steroid injection. It is the most ubiquitous intervention in orthopedic clinics worldwide.
And I want to be clear about why they are so popular. They work remarkably well for immediate pain relief.
They really do.
A patient walks into the clinic limping, unable to bear weight. The physician injects a potent corticosteroid directly into the joint capsule.
And within 48 hours, the inflammation plummets.
The swelling vanishes, and the patient walks out feeling a dramatic, almost miraculous reduction in pain.
Corticosteroids are incredibly potent immunosuppressants.
How do they work in the joint?
They enter the joint space and forcefully shut down the synovium's panic response. They inhibit the migration of those inflammatory macrophages. They halt the production of those destructive interleukins we discussed. They effectively freeze the inflammatory cascade in its tracks.
And this is where we have to discuss the revelation from the clinical data that is incredibly difficult to process.
It is very heavy data.
We are looking at long-term outcome studies, tracking thousands of patients over years of repeated steroid injections. And the hidden cost is staggering.
Staggering is the right word.
The evidence clearly demonstrates that repeated intra-articular corticosteroid use is actually associated with accelerated cartilage volume loss over time.
I really want the listener to process that statement. The intervention designed to save the joint is actively destroying it.
How is that physiologically possible? I mean, if the steroid stops the inflammation and we just established that inflammation causes the cartilage to break down, shouldn't the steroid protect the cartilage?
That is the logical assumption.
Yeah.
And it is exactly why this practice went unquestioned for so long.
So it's actually happening.
We have to look deeper into the pharmacology of corticosteroids. While they shut down the inflammatory cells, they also exert a direct toxic effect on the healthy chondrocytes.
The builder cells.
Yes. the very cells we desperately need to preserve the cartilage.
You're saying the steroid poisons the builder cells.
It fundamentally alters their metabolism. Corticosteroids bind to glucocorticoid receptors inside the chondrocytes.
Okay, and what does that do?
This interaction suppresses the transcription of specific genes responsible for synthesizing type 2 collagen and aggrecan.
Which are the fundamental building blocks of the cartilage matrix.
Exactly. It turns off their ability to rebuild. Furthermore, high concentrations of steroids can actually induce apoptosis.
Programmed cell death.
Yes, in healthy chondrocytes.
That is deeply concerning. So the steroid chemically stuns the builder cells, stops them from repairing the micro damage of daily walking, and in some cases, actively kills them.
Yes. So while the patient feels absolutely no pain because the inflammatory signals are muted, their cartilage is quietly, rapidly degrading.
It is the illusion of a fix.
It is. We are blindly repeating these injections every 3 to 4 months, lulling patients into a false sense of security.
They go back to running, hiking, or carrying heavy loads because the joint feels cured.
All while the structural integrity of the cartilage is literally evaporating beneath them.
I want to pose a question to you, the listener. If a treatment buys you 3 months of comfort, allowing you to walk without pain, but fundamentally erodes the physical architecture of your knee, accelerating your path to a metal and plastic joint replacement, are you actually healing?
No, you aren't.
Or are you just borrowing time at an exorbitant biological interest rate?
You are bankrupting the joint. You are trading structural longevity for temporary pain masking.
It is a deeply flawed biological exchange.
It is. We are essentially sacrificing the long-term viability of the tissue for short-term symptomatic relief. And it is absolutely vital that patients understand this mechanism before consenting to repeated chronic steroid exposure.
This realization forces an immediate pivot in clinical thinking. I mean, if corticosteroids are actively accelerating the decay, we have to look at the alternative injectables.
I have to.
If we cannot safely use steroids to suppress the fire long-term, what about the other needles doctors reach for? Are they any better, or do they represent a different kind of trap?
Let's analyze hyaluronic acid, or HA injections.
These are commonly referred to as the gel shots, right? The lubricants.
Yes.
What is the mechanism here?
To understand hyaluronic acid, we have to look at the synovial fluid itself. Healthy synovial fluid is highly viscous.
It's thick.
Right. It acts as both a shock absorber and a frictionless lubricant.
Okay.
The primary molecule responsible for this viscosity is naturally occurring hyaluronic acid.
But in an arthritic knee, that changes.
Dramatically. In a highly osteoarthritic knee, the quality and concentration of natural HA degrades significantly. The fluid becomes thin, watery, and loses its protective properties.
It's like the oil in your car breaking down and losing its viscosity. The metal parts start grinding.
Exactly. So the intervention here is called viscosupplementation.
Viscosupplementation.
Yes. By injecting a synthetic or avian-derived hyaluronic acid directly into the joint capsule, we are attempting to restore the biochemical environment. We are artificially increasing the viscosity of the fluid.
And from a biological standpoint, this seems far safer than steroids. We aren't chemically stunning the chondrocytes or inducing cell death.
It is significantly safer from a cellular toxicity perspective. For many patients, viscosupplementation offers genuine symptom relief.
Because it improves the gliding mechanics.
Right. It improves the gliding mechanics between the degraded cartilage surfaces, which can mechanically reduce the irritation on the synovium.
It alters the joint environment rather than aggressively suppressing the immune system.
Precisely.
But, and this is a massive, based on our investigation into patient outcomes, there is an insidious behavioral trap inherent in HA injections.
A huge behavioral trap.
Because the gel shot doesn't actively destroy the cartilage like steroids do, both physicians and patients feel comfortable utilizing it repeatedly.
Yes.
A patient gets a shot, feels the mechanical relief, goes back to their normal life, and then 6 to 8 months later, as the exogenous HA breaks down, the pain creeps back.
So they return to the clinic for another injection.
Exactly. And before they realize it, they have become entirely dependent on the needle.
It's passive management.
They fall into a cycle of passive management. They never address their muscular strength deficits.
Never.
They never address their baseline metabolic health. They never correct the chronic mechanical overloading that caused the initial pothole in the first place.
It's just a Band-Aid.
I find this approach deeply concerning because it represents an active surrender of patient agency. You are outsourcing the survival of your joint to a syringe every half year, while the underlying biological disease quietly, relentlessly marches forward.
It is the definition of a medical crutch. And to be clear, a crutch is an absolutely vital tool when a leg is broken.
Right.
But if you rely on that crutch forever, never utilizing the leg, the muscles atrophy, the bone density drops, and the limb weakens.
The same logic must be applied to the next category of injectables, which represent what many call the great orthobiologic hope.
Ah, yes. Platelet-rich plasma, or PRP.
This is the intervention dominating the conversation in longevity clinics and sports medicine right now.
It is everywhere.
For the listener unfamiliar with the process, this is an autologous treatment, meaning it comes from you. The physician draws your own blood, spins it in a centrifuge to separate and concentrate the platelets, and then injects that highly concentrated platelet plasma back into the arthritic joint.
Yes, and we need to approach PRP with extreme precision. We have to separate the legitimate science from the immense commercial hype.
Because there is a lot of hype.
So much hype. But there are recent international orthopedic consensus statements that strongly support the use of PRP, specifically for selected patients with mild to moderate knee osteoarthritis.
What is the biological rationale? Why would concentrated platelets help a degenerating knee?
Platelets are best known for their role in blood clotting, but they are essentially biological reservoirs of growth factors. When activated in the joint space, they release hundreds of distinct proteins, including transforming growth factor beta, vascular endothelial growth factor, and platelet-derived growth factor.
PGF-beta, VEGF, and PDGF. And what do these growth factors do to our active crime scene?
They are profound modulators of the joint environment. They can significantly alter the inflammatory cascade we discussed earlier.
They communicate with the angry synovium.
Yes, signaling it to downregulate the production of those destructive interleukins. They shift the environment from catabolic, meaning tissue breakdown, to anabolic, or tissue stabilizing.
That sounds incredibly promising.
It is. In many rigorous clinical trials, PRP outperforms hyaluronic acid in long-term symptom relief and functional improvement.
But this is where I want to challenge the narrative surrounding orthobiologics. We have to crush the hype right now because the marketing has vastly outpaced the biology.
Unfortunately, yes.
Patients are spending thousands of dollars out of pocket on PRP, convinced they are buying a fountain of youth for their knees. PRP is an environment modifier. It is not a guaranteed cartilage regenerator.
I agree completely. It is a vital distinction. If you have an end-stage bone-on-bone osteoarthritic joint where the cartilage matrix is entirely absent, PRP is not going to magically resurrect dead tissue.
Right.
It cannot regrow a pristine, millimeter-thick layer of hyaline cartilage out of thin air. It modulates inflammation. It does not turn back the chronological clock of end-stage structural failure.
Which naturally leads patients to ask, if injections can't regrow it, can a surgeon fix it?
Right, the surgical option.
We should briefly touch upon the restorative surgical techniques. Things like microfracture, collagen-based scaffolds, or matrix-induced autologous chondrocyte implantation, MACI.
These are highly sophisticated surgical interventions. In MACI, for example, a surgeon harvests healthy cartilage cells from a non-weight-bearing area of your knee.
Then what?
They send them to a lab where they are multiplied into the millions and then surgically paste them back into the cartilage defect.
I mean, that sounds like the ultimate cure. Why isn't everyone over 50 getting this?
Because the biological context is entirely different. These restorative surgeries are strictly indicated for isolated focal defects.
Okay, what does that mean in practice?
They are designed for the 25-year-old athlete who tore a single chunk of cartilage during a soccer game, but has an otherwise perfectly healthy, non-inflamed joint. They are entirely inappropriate for the 60-year-old patient with widespread, metabolically driven inflammatory osteoarthritis.
Because the environment is too toxic.
Precisely. If you implant millions of delicate, newly grown cartilage cells into a joint space that is actively raging with destructive interleukins and synovial inflammation, the new cells will simply be slaughtered by the ongoing disease process.
Wow.
Slaughtered. Furthermore, these surgeries require immense financial resources and a grueling, strict, non-weight-bearing rehabilitation protocol that can last for 6 to 12 months.
It is just not a scalable, biologically viable answer for the aging adult population facing systemic joint decay.
No, it's not.
This brings us to the heavy, rather grim reality of our current clinical protocols. When we look at the landscape of joint preservation for the aging adult, we are effectively trapped.
We really are.
We are caught between toxic steroid injections that silently erode the architecture, passive lubrication dependency that ignores the root cause, orthobiologics that are overhyped and underdeliver on regeneration, and surgical interventions that are biologically incompatible with the disease.
It is a dark reality. The absolute ceiling of arthritis care for over half a century has been symptom management and disease delay, never true biological reversal.
But this dark reality is exactly what sets the stage for the true breakthrough we convene to discuss today.
Yes, this is it.
This is where our investigation pivots. When you examine the data from the late 2025 Stanford medicine study, the tone of this entire conversation shifts from deep concern to intense investigative awe.
It is truly awe-inspiring science.
These researchers didn't look for a better mechanical lubricant. They didn't look for a stronger immune suppressant. They asked a fundamentally different question. Can we target the actual biological aging pathway of the cartilage itself?
This is the paradigm shifts we have been waiting for in longevity medicine.
Let's get into it.
The Stanford researchers focused their attention on a highly specific intracellular enzyme known as 15-PGDH.
Okay, 15-PGDH. We need to unpack this meticulously. What is this enzyme, and why is it the key to the castle?
To understand 15-PGDH, we have to revisit prostaglandins.
The molecules the NSAIDs block.
Exactly. Earlier, we discussed how NSAIDs block prostaglandins to stop inflammation. But biology is never that simple.
Of course not.
There are many types of prostaglandins, and some of them are absolutely vital for tissue regeneration. Specifically, a molecule called prostaglandin E2, or PGE2.
Okay, so PGE2 is the good guy.
In the context of cartilage repair, yes. PGE2 acts as a potent regenerative signal. It tells stem cells and chondrocytes to proliferate and rebuild damaged tissue.
That sounds exactly like what we want.
It is. When we are young, if we injure our cartilage, PGE2 spikes, triggering a repair response. But here's the biological tragedy of aging. As we get older, our cells begin to overproduce the enzyme, 15-PGDH.
And what does 15-PGDH do to our regenerative signal?
The PGDH stands for prostaglandin dehydrogenase. Its specific biological function is to degrade and destroy prostaglandin E2.
Oh.
Think of 15-PGDH as a sponge that aggressively soaks up and eliminates the regenerative PGE2 signals in the joint.
Wow.
And as we age, the concentration of this sponge increases dramatically.
So let me get this straight. It's not that our cartilage forgets how to heal. It's that the signal telling it to heal is being intercepted and destroyed by this enzyme before it can even reach the cells.
Exactly. The regenerative capacity is blocked by our own aging biology.
That is just fascinating.
The Stanford researchers identified this precise mechanism. They hypothesized that if they could chemically block the 15-PGDH enzyme, if they could remove the sponge, the natural levels of regenerative PGE2 would restore themselves and the cartilage would begin to repair.
How did they test this?
They utilized aged mouse models. They took mice that had naturally developed osteoarthritis due to aging, as well as mice with mechanically induced joint injuries. They then introduced a targeted molecular blockade, a specific inhibitor, to shut down the 15-PGDH enzymatic pathway within the joints.
And the results detailed in the report are just, they are staggering.
Unbelievable.
By blocking this single enzyme, they didn't just numb the nerve endings. They didn't just alter the viscosity of the fluid. The enzymatic blockade actively promoted real structural cartilage regeneration.
Yes, real repair.
The damaged cartilage in these aged osteoarthritic joints showed profound signs of cellular repair. The chondrocytes woke up and started laying down new matrix.
And simultaneously, the clinical osteoarthritis-related pain behaviors in the animals were significantly objectively reduced.
We must emphasize why this matters so profoundly for human longevity, even while strictly acknowledging this was an animal model.
It is vital to emphasize this. For decades, the ultimate frustration in orthopedic medicine was the perceived biological inability to coax a damaged mature chondrocyte back into a regenerative state.
The dogma was absolute: cartilage cannot regenerate.
Right. But this study dismantles that dogma at the molecular level. It mathematically proves that the biology of cartilage regeneration is vastly more modifiable than the medical community was led to believe.
It proves that the regenerative switch actually exists inside the genome.
It does.
I want to pause here because the implications are enormous. We are no longer just greasing the gears of the machine or drugging the pain receptors so the patient ignores the damage.
No, we are far beyond that.
We are talking about intercepting the biochemical signal of aging itself. We are whispering to the tissue at a molecular level to stop dying and start rebuilding. It is a profound conceptual leap from palliative care to curational biology.
It is a massive leap. But as longevity researchers, we must ground this conversation with crucial, uncompromising medical caveats. The biology is sound, but we are looking at a mouse model. The metabolic pathways of a laboratory mouse do not map one-to-one with the complex, multi-decade metabolism of a 60-year-old human being.
Right. So a patient listening to this cannot simply call their orthopedic surgeon tomorrow, cancel their scheduled knee replacement, and demand the Stanford 15p-GDH shot.
Absolutely not. This targeted enzymatic blockade is currently navigating the grueling multi-year process of moving from animal models to FDA-approved human clinical trials.
It takes time.
We must not allow the sheer hope of this mechanism to override our clinical reality.
Yeah.
It does not reverse severe, end-stage human osteoarthritis with a single injection today.
So what does this breakthrough actually mean for the patient right now?
What it signifies is a definitive transition into a new era of less invasive regenerative medicine. It serves as the ultimate proof of concept that future joint treatments will be regenerative, not just palliative.
The timeline is accelerating.
It is. But bridging the gap between the laboratory breakthrough of tomorrow and the painful clinical reality of today requires immediate, highly disciplined action from the patient.
This brings us to the most urgent part of our investigation, the essential longevity protocol.
The required action.
If we know that the molecular cavalry is coming, but it might take 5 to 10 years to reach widespread clinical availability, what must you, the listener, do today to ensure you actually have a biologically viable joint left to save when these therapies arrive?
Let's look at the data surrounding patient behavior.
We saw a deeply concerning trend in the clinical analyses regarding the global lockdowns of the early 2020s. Patients whose daily step counts plummeted, or patients whose joints deteriorated incredibly rapidly after a well-meaning doctor simply told them to rest.
I must deliver a stern, unequivocal medical directive regarding this exact phenomenon. The absolute worst thing an osteoarthritis patient can do, barring acute, severe mechanical trauma, is to stop moving.
Stop moving.
Yes. The concept of resting an arthritic joint into health is a biological fallacy. Rest is rust. When you become sedentary, you actively accelerate the cellular death of your joint.
We really need to explain the physics of this because it seems completely counterintuitive to someone in pain. If the movement hurts, why does stopping movement cause more damage?
It comes back to the unique vascular anatomy of cartilage. We established earlier that cartilage has no blood supply, none.
Right.
It cannot receive oxygen or nutrients through the circulatory system like a muscle or an organ can. It relies entirely on the mechanical fluid dynamics of the joint.
It's a sponge analogy.
Precisely. Imagine your cartilage as a dense fluid-filled sponge. When you take a step, the mechanical compression of your body weight squeezes that sponge.
Squeezing out the bad stuff.
Yes, forcing out the toxic metabolic waste products and inflammatory cytokines into the joint space where the lymphatic system can clear them.
Okay.
When you lift your leg for the next step, the compression is released. The sponge expands, actively pulling in fresh, nutrient-rich, oxygenated synovial fluid.
So the physical act of walking is literally the heartbeat of the cartilage. It is the only way the tissue breathes.
Yes. If you stop moving, if you sit in a recliner all day because you're afraid of the pain, you paralyze that fluid pump.
You suffocate the joint.
You starve the chondrocytes of oxygen, and you allow the toxic inflammatory waste to pool and stagnate inside the joint capsule. Sedentary behavior is a death sentence for an arthritic joint.
I can hear the pushback from a listener who is currently in agony. Are you seriously telling me that the very movement causing my knee to scream in pain is the exact medicine I need to save it?
We are telling them exactly that, but with a critical caveat. We are not advocating for mindless, painful pounding on a treadmill.
No.
We are talking about structured, highly strategic loading. The protocol to buy time requires a comprehensive, uncompromising biological approach.
So where do the injections fit in?
Injections, whether you opt for hyaluronic acid or PRP, must only ever serve to support this protocol. They can never replace it.
Let's break down the mandatory long-term strategy. What does structured loading actually look like for someone whose knee hurts when they walk?
It begins with altering the mechanics of the load. If walking hurts, you must find a way to compress the joint without sheer force.
How do you do that?
This means utilizing isometric contractions, holding a position under tension without moving the joint through a painful range of motion.
Like a wall sit.
Exactly. It means slow, controlled eccentric loading to build the muscular scaffolding around the joint.
The surrounding muscles.
Right. The quadriceps, the hamstrings, the gluteal complex, these muscles act as active shock absorbers.
Okay, I see.
If they are weak, 100% of the mechanical force goes straight into the degraded cartilage pothole. If they are strong, they absorb the impact, protecting the remaining tissue while still forcing the synovial fluid to circulate.
And we cannot ignore the systemic amplifiers we discussed in the first section.
Yeah.
You cannot outtrain a biochemically toxic environment.
Absolutely not. The longevity protocol requires aggressive, uncompromising weight control. And as we established, this is not merely about mechanical load.
It is about the fire.
It is about extinguishing the systemic inflammatory fire feeding the joint destruction. It requires profound metabolic and dietary improvements.
So managing blood sugar.
Yes, managing insulin resistance, eliminating highly processed inflammatory foods, and optimizing your lipid profile are not just cardiovascular interventions, they are primary orthopedic interventions.
You have to fix the whole system.
You must lower your systemic biological threat level so your synovium stops overreacting to the structural damage.
This has been an incredibly heavy, dense investigation. We have journeyed deep into the microanatomy of joint failure, exposing the violent, active inflammatory cascade that destroys cartilage.
It is a violent process.
We have confronted the shocking long-term structural dangers of standard corticosteroid protocols and the passive behavioral traps of modern injectables.
Which patients really need to be aware of.
But through the Stanford 15-PGDH enzymatic pathway data, we have uncovered a legitimate, scientifically validated beacon of hope, proving that cellular regeneration is biologically possible.
The molecular science is advancing at an unprecedented rate.
Yeah.
But my final warning to anyone listening, anyone staring down the barrel of joint degeneration is this. You must stop looking for a passive shortcut.
The crutches won't save you.
A syringe will not save you from a sedentary lifestyle.
Mm.
A pill will not outwork poor metabolic health. You must understand the sheer biological complexity of this disease, and you must attack it with an evidence-based long-term strategy of muscular strength and metabolic optimization.
You have to do the work.
You must actively, aggressively buy the time necessary for these regenerative molecular technologies to clear clinical trials and become real-world medicine.
The dogma is dead. The cartilage can heal. And as we conclude this urgent panel, I want to leave you with a profound, lingering question to turn over in your mind as you consider your own longevity.
It's the ultimate question.
If the targeted blockade of a single enzyme like 15-PGDH can trigger the active structural regeneration of cartilage tissue that the entire medical establishment previously believed was dead and gone forever, well, it raises a staggering, almost terrifyingly exciting question.
It does indeed.
How many other inevitable signs of systemic aging in our bodies, the stiffening of our arteries, the decline of our cognition, the aging of our organs are not inevitable at all, but are just waiting for us to find the right molecular switch?